Hi, everybody. Welcome to the July Pelvic Health Explorer expert interview. I'm here with Michelle Marikos, and I'm over the moon excited about this. It's not very often that we get to talk to the other side of the coin. In these expert interviews, we're always talking to other clinicians, healthcare providers on how we deal with people with pelvic pain and pelvic health problems. And pelvic pain goes along with back pain, shoulder pain, neck pain, widespread pain, IBS, everything. And today we are so fortunate to have Michelle with us because she is from the other side of the coin. She is an advocate for clients and having been one herself. And she's created a slew of resources and has some great practical information for all of us to share. Michelle, tell us about who you are and just a bit of your origin story and how you got into this work.
Thank you so much for having me, Susan. I really appreciate being here. My story actually starts in middle school. So originally, I had very difficult periods. And at that time, what was prescribed was birth control. So I immediately went on birth control when I was 12 years old. And I have a family history of pelvic pain. My mother lived with pelvic pain. It was common in our family to have, endometriosis. And at that time, I wasn't diagnosed with endometriosis, but it was okay. We're just gonna, put you on birth control, and this is what you'll do. Living with that in my early teens, late teens, and early 20s, and then in my early 20s, I was pushed off of a balcony and fell off of a second-story balcony and broke my neck. And so that was at the time very devastating towards my life, that I lived with chronic pain and this very extensive injury. So I went down the rabbit hole of opioids and really living the journey of chronic pain. As I'm doing that in my early 20s, I'm still continuing to be on birth control and dealing with my endometriosis as it was. And then I ended up going to the Mayo Clinic for their pain rehabilitation program and tapered off of all of the medication, learned about how to live with chronic pain from my neck injury. And at that time, I was dating my husband, and then I got married to my husband, and we wanted to have children. So this is kind of that point of no going back with pelvic pain and your pelvic journey. The scenario of, okay, we want to have children and we're not getting pregnant. What's happening here? I had had a previous surgery on one of my ovaries because of ovarian cysts. And so I went in immediately and had scar tissue cleaned up and had the ovarian surgery again.
Mm-hmm.
And then it was like, okay, we'll do this surgery and we'll continue on, trying to get pregnant. That was not working. So we went to the next step and kind of doing all of the testing. At the time, we live in a small community in Southern Oregon, and we don't have a lot of resources for infertility or information about infertility. It was, you go to this small clinic, we can help you, or we can't. And then you go to the big city and you're kind of passed along from doctor to doctor. Through that journey, it was interesting because I had lived, this parallel process of this neck injury and really understanding how the medical system works, where it's, you're passed along and you're passed along and you're passed along. And so I was kind of reliving that journey with infertility. That journey of infertility was 5 years and a very difficult emotional journey. It was difficult physically also, but I could handle the physical pain. I just couldn't handle the emotional pain of everything that goes into pelvic pain, endometriosis, infertility, being really gaslit in your journey of nothing's wrong with you, try this or try that, or we haven't found anything on these scans, we're going to do another test. And being in the middle of it and really wanting an end result of having a child, so many emotions coming up with that journey and not knowing that those emotions are okay, not knowing that those emotions are very common, not really being able to express any of those emotions. And, the infertility journey really opened my eyes to what the pelvic pain community goes through and everyday, struggles, that this is not, something that a large population of people experience. And when we do experience this, how much support is needed that is not there. So during my infertility journey, I was already working as a peer support specialist for chronic pain because of my neck pain, and realizing as well that pelvic pain, endometriosis, infertility is not spoken about in the community as well. Among people going through infertility, you don't speak about it until somebody else speaks about it. And you're like, oh, I had a journey also. And then it's that connection of common ground of like, yes, we go through these horrific experiences, but we're allowed to share because we've both gone through it. So I was lucky enough to be able to do the infertility journey and learn so much about it. But we chose to do egg donation. We had a son that I carried during COVID. So it was infertility and COVID. And he is now 5 years old. He just turned 5 in June. So that was our miracle. His name is Mika. And the story didn't just end with his birth, because
Right.
after his birth became kind of the real journey. The pain and all of my symptoms got much, much worse after having a child. I was so blessed to have a wonderful pregnancy that I had, very low symptoms at that time. I didn't have pelvic pain. I was feeling pretty good overall during pregnancy. And about a month after I had my child, all of the symptoms came back 10 times worse. And there was so many things that I had never talked about um, around sexual intercourse pain. And I didn't know that was a symptom. I didn't know because nobody had ever asked. And I don't know if I was ever going to talk about it if nobody ever asked. I was put on some medication to try and deal with all of those symptoms. That medication was very expensive and did not work and actually caused more pain. So then it was like, okay, next steps, we'll do a hysterectomy. And at the time, that was a devastating prospect of having a hysterectomy of, I don't know if I can do this. It took me a good 6 months to wrap my head around looking at that surgery. I'd gone into the surgical consult and just couldn't really mentally and kind of emotionally deal with it, and waited a few months. And then I went back in and did the consult again of like, okay, say it all again, because I don't think I was paying attention the first time. And that second time it was like, okay, I think I can do this. I think I can, go through this surgery. If it's going to give me any kind of prospect of living with half the pain, then that's okay. So I did do the surgery. After the surgery happened, I ended up having some severe hormonal depression, and actually ended up having one of the worst conversations I've had with a provider in a long time, expressing my depression and that I was in a very, very dark place that I had not been in before, and being told that that has nothing to do with hormones, and really being gaslit. Knowing what I know about being a peer support specialist and what I know about the medical system, that I was, in a place that I could get myself to a counselor, get myself onto antidepressants, get myself into a safe place. But if I didn't have those resources and the capabilities to do that, I don't know what would have happened. So that really pushed me into what I do now. And so what I do now is that I help providers with difficult conversations and open dialogues around everything that goes around with pain, pelvic pain, any kind of pain, but also mental health as well. We know that pain and mental health go hand in hand, and that these conversations are going to happen, but they don't need to go sideways, on either part. And I love that you said earlier about, the flip side of the coin, and the parallel process of what the patient is going through is very similar to what the provider is going through with,
Hmm.
high anxiety about these conversations. These conversations are going to happen. They need to happen. And we need to be able to, have these open dialogues.
Hmm. Yeah, it's definitely a journey, one that actually has kind of a binary presentation because you had the endo, obviously, when we start our beginning of our reproductive years as a child or a young, a preteen, getting our period started and then finding this devastating pain. And the first thing they do is hand you a med, and at 12, you're like, I just want it to go away. I don't understand it. I just want it to stop. And then having the very big injury that you had in your 20s, just the adverse effects and the trauma that you already experienced in your young life, and then crawling yourself out of that chronic pain hole, so to speak, and finally
Mm-hmm.
getting yourself into a treatment where actually they obviously worked on mind body.
Yeah.
And, it wasn't
Yes.
like you're just going to have to tough it out and get off your meds. It was like, the whole psychosocial piece for you there. It sounded like you were in a pretty complete program that actually led you to peer support, which
Mm-hmm.
gave you the opportunity to have some agency for yourself in spite of all of this terrific fertility, pelvic pain journey, and still not even being able to connect the dots that, dyspareunia or pain with sex is part of it, and not understanding, and nobody really sitting down, and nobody actually. When did they finally decide that you had endo? Was it when they did a laparoscopy and saw the cyst, or what was it?
No, no, it was after the hysterectomy. It showed up on the hysterectomy and that I had the endo and the adenomyosis.
Yes.
So, and
Hmm.
that like was never talked about before. I'd never heard adenomyosis before. Nobody had ever said anything about that. It was always like, oh, we think you have, and then we'll just keep going in and looking. And then nothing was ever found until the hysterectomy and the biopsies during the hysterectomy of like
Right,
the actual tissue.
right. And and at that time they only knew to look around the uterus and not anywhere else, so, and they probably weren't staging ovarian cysts either for endo. But as we well know now, endo can be everywhere. But you had never even received a diagnosis of adenomyosis, which, it's
Yeah.
amazing that you were able to carry a child and be able to do the things that you really wanted to do, but not even realizing that you had this devastating thing going on. And so as soon as you came out of the pregnancy bliss, like we like to call it,
Hmm.
the hormones crash afterwards and everything, you were left with a really just without answers and actually very little support. How did you get yourself to counseling? Did you just, you knew you were in a dark place and you just said, I know this, I just need to use your own agency that you developed being a peer support specialist in this binary journey with your chronic cervical pain?
I'd worked really hard on my mental health throughout my chronic pain journey, on and off, medication. And at the time, being off of antidepressants and like, okay, I'm doing pretty good. And then, of course, you don't know what you don't know. You don't know that the
Yeah.
hormones are going to hit or not hit, and that you're going to be absolutely really dropped from the sky of, okay, this is happening and I don't know what to do about it. And I was lucky enough to have a wonderful support system that my husband caught me in it of like, I'm going to have to call the emergency number. I have to call someone. I can't deal with you, threatening to commit suicide and
Hmm.
suicidal ideation. And I hadn't had that strong of ideation ever before, and it
Right.
scared me to death, and it scared him to death. And I wasn't going to be able to chemically pull myself out of it by myself. At the time when I had that very difficult conversation with the surgeon and was dismissed, it, like, I wanted, we're always looking for the answers. Living in these very difficult situations, we're always looking for the why. Why is
Hmm.
this happening to me? Why am I going through this? Why are these medications not working? Why are these, things happening? And at the time, it was like, why am I having these horrible feelings? And to be dismissed of, well, there's no research behind that. Whether the research was there or not, it didn't really matter. I needed to be told, you need some help and we're going to help you and let me walk you to the next office and get you the medication that you need to get yourself out of the situation. And that was something that I ended up having to, kind of shake my head off of, okay, I have to do this by myself apparently. And that
Hmm.
nobody else, we should never have to be alone in this journey. And, feeling alone makes it so much worse.
100%. And, just the bravery of going through what you did and really understanding that there is help for me. Just have to find it. And now that's kind of brought you around full circle here, in your advocacy work for others, for not just the clients, but for the providers to have these conversations. And I know people oftentimes will tell me, it's not my scope of practice. I shouldn't be talking to people about this. And your answer to that is
You do the customer service thing of like, I don't have the answer, but I'm going to find somebody that will.
exactly
Of that is,
100%.
you
Do not
have to,
have,
yeah, don't leave people alone.
you
Don't
don't
leave
have
people
to.
alone in their journeys.
Yeah, and it's one of the things I always say, you don't have to know what to do with it. As clinicians, I always tell the clinicians I mentor and work with that you should have a wheel of support for your own practice. Who are your go-to people for postpartum depression? Who are
Mm.
your go-to people for mental health issues that come up with pelvic pain? Who are who are these people? Because you're not going to send somebody with a digestive disorder to an eating disorder clinic. You're going to send them to somebody who can deal with digestive disorders. The same here is like, who is really good with the sexual intimacy part? There's
Yeah,
counseling for that. There's counseling for postpartum depression. There's counseling for pain and depression with pain and the emotional, like you talked about so beautifully, the emotional upheaval that comes with not just the fact that you were infertile, but you were still dealing with pain and you had no idea that even like trying to have intercourse with your husband was painful. And what can we do about this? But you didn't even know if you could
yeah.
ask.
No, because of the shame and that, I'm the only one that's going through this. You feel like on an island so much of like, oh, I can't talk about these things because I don't want to be ashamed, feel
Hmm.
ashamed already, just even feeling that feeling of being uncomfortable during intercourse, then even talking about it is another level of shame and being ashamed.
I think
Especially if
you,
you have a like male doctor and the male doctor is asking about it, you're like, yeah, okay. I mean, I appreciate you asking, but I don't know how to answer this, and I don't know what to do with this information. This isn't normal. It's like, oh, well, I feel better that it's not normal, but I don't know if I feel comfortable having the conversation.
right. And just being open and curious as a practitioner to what the person's story is can help so much. To at least be felt that you're heard and to feel like that somebody is trying to open a container of trust so that you feel safe to
Yeah,
talk about it, whether they have the answers or not. Oftentimes, being able to talk about it is the first thing that needs to occur.
yeah,
And I think pelvic health providers are all very passionate about their work. And yet
absolutely.
they still kind of like, oh, this, and they have empathy for their clients, but they're just kind of like, I don't want all that to happen. But again, they're the one place where it does happen and it can happen because you're sitting right in their office with them and this is what they do. They're going to tell you
Yeah,
that pain with sex isn't normal. Let's see what's going on. Let's look at the neuromuscular connections to see. Let's check out your tissue and see if maybe we need to get you some hormonal support for your tissue. Let's figure this out together, but also recognizing that who's your support system? And have you ever talked to anybody about this? What do you need? And let's get you to somebody that can help you with your whole pain and depression part around this, the mental piece of this, because it's so tied up into everything.
it really is.
Tell us about your resources that you have for people, for clinicians and for clients. Like, tell us what you have and kind of how you operate and Then we'll get into like a little bit about how people can access some of that stuff.
Yes, absolutely. So we've created 52 scripts. There is five different sections of difficult dialogues. And so we go through these five different sections of dialogue. So the first section, for example, is about diagnosis and treatment of any type of chronic pain. And what we do with our dialogues is that we start the dialogue, give information to providers around the different wonderful resources that we can use. So there's a lot of different models that providers can actually use to start those conversations about validating the patient's experience. How do you do that? What do you say? Because so many times in this work, I've gotten asked, for the actual scripting. Providers want, I say this, the patient says this, then I say this, and then the patient says that, which is wonderful. And it gives you ideas to, okay, well, obviously, we can't do it word for word because we don't know,
Right.
every conversation is going to be different. But here are some ideas of, what patients feel when you ask these questions, what they're thinking when you ask these questions, and how do you respond to that? So it's a lot of motivational interviewing,
Yeah.
value-based information gathering of finding out what values do I have as a patient? Do I value obviously my marriage and my sexual intercourse, relationship with my husband, but I also value having a child and what does that look like? And, I value spending time with my child and how do I do that living with chronic pain and being able to find out the values that your patients hold dear really can transfer into their care and how you care for them, knowing about their values. In that first series of dialogues, we go through how to really find out the values and ask the questions that a patient will be able to answer in a way that's understandable for the provider and also makes the patient as comfortable as possible as well. That's kind of the first series is about diagnosis and management. Then we go through medications and how to talk about any kind of medication in a very broad way, but really bringing up information about medications, and patients and providers can have these conversations about medications and how important that those conversations get missed. Patients don't feel comfortable saying I'm having side effects like this or I'm having side effects like that. So really diving into those conversations. That series 2 is about medication. Then we go through social relationships and how that support system can help the provider, bringing in your support system and what the provider can talk to the support system about and how important those relationships are in the treatment model as well. And then we go through mental health. We have a whole series on mental health and how to talk to patients about mental health and depression and anxiety and kind of all of the scenarios that happen with chronic pain in general and your mental health. So yeah, we dive into kind of everything that is ever talked about in medical visits, and we do a lot of scripting and a lot of kind of value-based care in that, and self-efficacy of how to build self-efficacy for their patients. And then as the reverse of that, we have the opposite scripting of how patients can talk to their providers about all of these things. So patient-centered, we have a whole series of patient-centered scripting for patients to be able to be comfortable with their providers and what patients, can ask their providers to get the opposite answers from their providers and making their providers just as comfortable.
So it's like you start off with the relevance and the value. You dive into the treatments that have been done. What do they
Yeah.
know? What do they
Yeah.
don't know? What do they
Yes.
feel has helped? What hasn't helped?
Yeah.
Right? So that we don't plow the same ground. It's like, tell me what you know about it. People know way more than we think they do. And when you honor the fact that they've got this knowledge base, it's empowering to them. It's like, I'm not somebody who just receives things. I really can contribute to my own care, which, kind of meshes in with the social support, how their mental state feels about all of this and what agency they can take back for themselves. And that
Yes.
always goes back to relevance. What is relevant for them in their life is going to be different for somebody else in their life.
Mm.
Focusing on what's relevant for them is what's important.
It really is. And it can change the way that treatment happens, creating the
Absolutely.
agency and the self-efficacy that I'm the one who's feeling my pain. What can I do about it? How
Hmm.
can you help me, take my own life back?
Exactly.
That because in so
Exactly.
many times patients feel so out of control in their own bodies,
Mm.
and we want to feel a sense of control that we may not be able to control all the pain, but we can control a lot of aspects of our life that go along with the pain.
Right. Right. It's like pain is inevitable, suffering is a choice. And the suffering is, and it's not a choice like they chose it, but they don't realize how much the suffering is part of their pain cycle. And suffering can change. And by doing that, the pain changes. And
Absolutely.
and I love how that all kind of keeps going back full circle because one of the questions practitioners always have is every time I talk about pain or pain neuroscience or trying to help people understand pain, they go away with the idea that I think it's all in their head. And it's like, so I love what you're doing on the other side, which is for the patient-centered, because some of the things our clients will always ask is, I would like to know this information about what happened in the surgery or about what happened here or what is going on here. I don't know how to ask my provider. I don't even know how to interview a provider to make sure they're going to be a good fit for me. And it sounds like there's some excellent resources for providers out there who are making some of these bridges for them. Here's how you talk to somebody about it. They're the right counselor for
Mm-hmm.
you. Here's
Mm-hmm.
questions you can ask your provider in a way that's going to go, oh, this person just needs some resources, or this person just really needs to be heard, or this person needs this because they're busy. So
Mm-hmm.
if we can get the client to feel comfortable in some of their questions that they want, it's like maybe you could reframe that question into this so it doesn't sound so negative and so it
Yes.
sounds like, kind of curious because people respond to curiosity versus like, you didn't tell me this, you didn't tell me this, you didn't tell me this. But instead it would be like, I'm really curious about how this has all come about. Like what
Mm-hmm.
was the key trigger that caught, from the biopsies that we'll just use your case from the biopsies. What does that mean?
Yeah.
And how does that relate to some of the symptoms I had? And can I expect that because I've done this that will change, or is there more for me to like think about? That kind of thing.
Yes.
So coming up with those and then coming with that kind of a curiosity, even from the patient perspective, is very helpful for them because then they're calmed down and they're not in their sympathetic crazy brain. They're like using all of their great, sage experience and wisdom that they have. No one can tell somebody what their experience is. Only they can talk about their experience.
Yes, absolutely. And the pain experience is so wide and varied. And I think that is taking into the big picture of that we have to, really look at this population of people living this experience exactly as that it's an individual experience.
Hmm. Yeah, I love all of this. There was a great research article that came out a couple of years ago looking at music. What they did was they had
Mm.
clients that were going to go see their physician around pain. And they looked at a couple of measures of anxiety and different things. And what they did in the waiting room, there was a group of clients who heard nothing. There was a group of clients who heard whatever music we piped through their headset. And there was a group of clients that got to choose the music they wanted to listen to. So here's the interesting thing. Obviously, the people who heard nothing, not any changes. The people who heard some music were definitely able to say before and after when they were ready to go in that they had changed. And then the people who sat and actually chose their music were at the top. And this is where the experience that you were just talking about comes
Mhm.
in. Because we know that 528 hertz music is calming and healing, may not jive with this other person's central nervous system. They may want to listen to this music. And for them, that brings their anxiety down and helps them feel more connected into who they are in their community and their tribe, versus somebody who's going to listen to something completely different. And we see that across regions, we see it across communities, we certainly see it from different backgrounds that people come from. And I always like to do that when I'm talking with people because their experience is different and people don't get that. They just think I have a pain experience. And it's like, but your pain experience is your pain experience. Because I hear people all the time say, that's not my pain. Whatever that is over there you're talking about, that is not my pain. And we have to not dismiss that. We have to say, tell me about your pain because your experience is completely different than the person next to you.
Yes, absolutely. And I think giving the choice in treatments as well.
Hmm.
I mean, choice in
Yeah.
music, choice in treatments, choice, how
Hmm.
much does that give me back into that control piece as well of like, if I
And
get
what
to
do you,
choose something, that
Mhm.
makes my experience my experience because I get to choose.
And by choosing, you're collaborating in treatment versus just do whatever you have to do. I'll put up with it because I just want this to get better. That's not going to help. And it's
Yeah.
like, again, that whole experiential thing, like we have several ways we can go about this. Where would you like to start? It's like, here's the ice cream shop. What
Mm-hmm.
flavor would you like to pick? Because all of them are going to
Yeah.
start helping, but you get to choose the first one. Like, okay, we can do all of these different types of techniques to make your, pain with sex better. Some of them are more aggressive than others. And some people may choose, I want to use that wand. It's really important for me to be able to have insertion, and that's where I want to go. And other people are like, I'm totally afraid of the wand. I'm not ready for that yet. Then let's start with what you feel like you can do.
Yep.
Let's figure this out.
Yes.
Let's work with it together and bring it forward. And I know people out there are listening and saying, yes, I know that we do that in the clinic, but I think we want to bring forward the idea that the more we gather the client's story, the more that we honor it and we find the relevance in it, the value, and help them, they'll write their own goals. When we do work this way, they know what they want and they want to try to get there. And then it's so much easier to kind of like work with the path collaboratively to help them and help bridge the gaps in their care.
Bridging the gaps, building that relationship. If you can build the relationship and create the trust,
Mhm.
changes everything.
Yeah.
And the fact that one of our basic kind of pillars in our difficult conversation scripts is building trust, but also knowing that patients are believed. I
Mhm.
always say that, we know when our providers don't believe us.
Mhm. All humans know when somebody's blowing smoke, right? We
Yeah.
know it. We have
Yes.
our BS meter where it's pretty easy to figure that out. Even if it's stuff we don't know anything about, you can pretty much tell if somebody's sandbagging the conversation. So yeah, I think that those are so important. The group that's listening to this, I can promise you, are practitioners. How can they, like, what can they find? How can they take a look at some of your resources?
Yes. So we have free sample scripts on our website under the
Okay.
resource section, movingthroughchronicpain.com.
Okay.
I'm always available to speak with anyone at support@movingthroughchronicpain.com. And people can always email me, reach out to me, use the resource section on the website. I have lots of blogs on the resource section as well. And then our 52 scripts are on the website as well, and those can be purchased. We also do workshops around all of the scripting as well to do some hands-on work and actually do role playing and practicing and getting
Mhm.
very comfortable with any kind of conversation that may come up around pain.
Yeah, I love that. I love the practical aspect of it because doing this work isn't passive. You can't read it and you have to do it. You've got to utter it out of your mouth. You've got to be the receiver and feel how it feels to be heard and know that that is so powerful from both sides. And I love the role playing and the dialoguing to make that happen and to imprint the work in even deeper. I would highly suggest
Mm.
if anybody listening to this has not done any type of coaching work, this might be a really good place to start to really kind of get into like, oh, what does that sound like? And maybe listen a little bit more and practice some of the things just a little bit more and take advantage of maybe a workshop of just like with like-minded, heart-centered professionals that want to make a change in their client's life. Jump in and do a couple of those and get your feet wet and and feel the power as the person receiving it as much as the person giving it. Because I know people when they enter into coaching type work, one of the best takeaways that they have is that their own life changes so much because they didn't realize how much they weren't being heard either. And, being able to express your own values and your own things that are important to you, even as a practitioner, what's important to you? What do you value the most? And if you're not in a situation where that's being fostered, there needs to be some conversations to help optimize that for you because you're going to lose it's one of the things that burns everybody out is when we're not honoring our values.
Absolutely, yes. And having one of those goals is, we want to create a safe space for providers as well, and really want to reduce burnout for them because this is important work that providers do, and we want to continue the important work that is being done.
This is fabulous. So down in the show notes, everybody, will be tell us the name of your website again.
Movingthroughchronicpain.com.
Movingthroughchronicpain.com. And you can reach Michelle at support@movingthroughchronicpain.com.
.com.
So take a look at it, see the resources, and we will definitely put this in the show notes so people can find it and be able to utilize this fabulous dialoguing resource that you guys have all created and you're supporting. Thank you again, Michelle, for your time and your energy today and what you're doing to change the health of many that are in chronic pain and pelvic pain.
Thank you so much for having me.